Hello and a warm welcome to all of our Gold viewers here today. I'm Kristen Schwarz, a licensed midwife and one of the MCs here at Gold. And I'm very excited. I have a special guest with me here today, Dr. Brenda Wagner. Welcome, Brenda. It's good to have you here today.
Well, it's great to be here. Thank you.
So, you will be speaking at the Gold Midwifery online conference in one of the add-on packages, and your presentation is absolutely a topic that is so needed. It's titled When, Why, and How to Think About the Thyroid in the Postpartum Period. We're going to talk about that in just a moment. But first of all, Brenda, tell us where you are in the world and a little bit about your professional background.
Right. So I'm actually in British Columbia. I'm in an area of British Columbia that's called the Okanagan. The main city in the Okanagan is called Kelowna, and I live about 30 minutes north of that, really out in the country with a beautiful view of the lake.
Mm.
If you haven't been to the Okanagan in British Columbia, I really encourage it. We've got great skiing, incredible wine, and actually Kelowna was just declared a UNESCO site for food. So the food scene in Kelowna is awesome, and it's beautiful in the winter. And if you want to retire in Canada, it's one of the number one places to retire because it's dry, the climate's reasonable, and there's great amenities. So
Beautiful.
that's where I live. I'm an obstetrician and gynecologist. I actually was living in the US when I went to university, and I was in a 7-year integrated pre-medical medical program at the University of Michigan in Ann Arbor. And I actually did an internship there in Ann Arbor. I did that in internal medicine because my American husband, who's from Ohio, and for your American listeners, he's a Buckeye and I'm a Wolverine. And so that's a pretty big cultural difference, probably bigger than the American Canadian divide. But he wanted to go to grad school in British Columbia at a place that's affiliated with UBC. And so I, being a Canadian who hadn't lived in Canada for a long time, but it was very familiar with socialized medicine or medicine for all, where there was an insurance, was pretty keen to come to Canada to do my residency. And so I did my residency at the University of British Columbia in Vancouver, a beautiful city, but an excellent residency program. And then we ended up staying in British Columbia. We didn't know that we would, but we've stayed in British Columbia ever since then, lived in various communities. And I mostly practiced in an urban center that's just south of Vancouver for most of my career, 24 years. And then since then, I've been working in rural sites, and now I just do rural support for communities that are short of obstetricians and gynecologists so that I'm sustaining midwifery in small communities around British Columbia, which is a very, very satisfying and enjoying part of my career.
Oh, beautiful. Yes, as you mentioned, midwifery and OBGYN care in those rural communities, as you know, if you've seen, and this is not just in the United States, but probably also in Canada, we have these health deserts, right? Not
Yes.
enough care, lots of hospitals closing, especially maternity wards. So this is so needed and wonderful work that you're doing there. So your presentation is about the thyroid in the postpartum period. Many of us practitioners, we always, we're so keen on discussing and treating thyroid in the pregnancy in that prenatal period, and then often we think like, oh yeah, that's something we need to postpartumly be aware of, but then, we're handing over care and so I feel like postpartum the thyroid is a little bit neglected, or is it just me thinking that? Or is it in my area
No,
here?
no, I completely agree with you. In fact, when I got asked to do this talk, I'm always keen to do a talk because when I do a talk, I get to learn. And I think that to be a good provider, we have to be a lifelong learner. And so I'm so supportive of the work that you guys are doing that's facilitating people being lifelong learners no matter where they're at. And so when I was asked to do this, I thought, I'm not sure there's enough to make an hour-long talk on this. And I was surprised. And I realized I had been neglecting the thyroid, and there's a few reasons for that. First of all, some of these thyroid disorders don't even occur until once the person is no longer 6 weeks, and we have this sort of artificial divide in our system where at
Yeah.
6 weeks they stop being seen by a maternity provider and go back to their regular provider who may know very little about maternity care and is also not clued into the thyroid. And I also just learned how often thyroid disorders are there and undiagnosed
Yeah.
because the symptoms of thyroid disorders actually line up pretty amazingly with the symptoms of being postpartum. And some of the main things that we see, women that are have postpartum depression, and women that are struggling with lactation, these are two things that are highly correlated with thyroid disorders in the postpartum period. And I think, well, I know I have not been, oh, you've got some postpartum depression. Let's just double check make sure your thyroid's fine, or you're having trouble with
Mm.
letdown, or you're having trouble with supply. It's true trouble with supply, not a perceived, which we know so many people worry about their supply, but their baby's growing fine and their supply is fine. But if we're actually having a poor growth, and we can't document that there's good supply, then we should be screening for thyroid disorders. So those things are
Hmm.
so common and in the postpartum period. So this is a really important area. It's an area where I feel like I neglected what I needed to be doing previously, where I've learned and hopefully will change and course correct and do things differently in the future. But I really hope that people listen in, because I think everybody will agree that there probably is some room to improve their practice and how they're
Right.
treating patients that are uh, hypo or hyperthyroid in that postpartum period.
I can imagine there will be some aha moments for some of our viewers going like, wait a minute, oh yeah, that could be thyroid. I didn't think about that. Or
Hmm.
maybe it could, maybe it's worth a shot testing for it. You talked about like that postpartum, it could go later, it could be an onset later than 6 weeks, maybe that are out of our care. It could be masquerading as typical postpartum tiredness, and such. But what have you seen, and what other misconceptions about postpartum thyroid health would you say are out there or you're familiar with?
Well, I think the number one thing is who to test in. And so in
Mm,
the talk, we give a really clear list of who you should be thinking about testing. And one of the big ones for me was the high incidence in postpartum thyroid disorders in people with type 1 diabetes. So I think
mm-hmm,
that that's the patient population where I would be saying, you know what, if you haven't been testing, please make sure you test that it's almost 20% of women with type 1 diabetes will have thyroid disorders in the postpartum period. So I think that's a common misconception, is that the
mm-hmm.
I think the common misconception is it's really not a big deal. But actually, what we learn is if it's affecting your mental health, if it's affecting lactation,
It's a big deal.
that's a big deal.
That is
So
a big deal. Yeah.
yeah, so we need to be more aware and more thoughtful. We need to identify women who are at risk. So anybody with thyroid antibodies, anybody with another autoimmune disorder, they're at increased risk. And so when we're transferring those people's care back to their primary care provider and away from their maternity care provider, we need to be cluing in, first of all and foremost, always the person, the pregnant woman or individual that's in front of us, or postpartum woman or individual that's in front of us. We need to make sure they are aware, because as we know in any healthcare system, the best advocate for the best care is always the person who we're talking about, the individual involved. But we also need to make sure it's in our handoff note to their provider saying this individual is at risk, be on the lookout for symptoms, and don't hesitate to test. We're not advocating for
Right.
universal testing, but if you've
Yeah.
got a suspicion, test that TSH.
Tessa teaches. And, I was just wondering about the guidelines and, what are the guidelines actually say not to test everybody, but like, do you think that needs, well, we don't want to test everybody, but do you think our guidelines need update? I feel like there is a little bit of a disconnect there somewhere, right?
Well, I think the guidelines that there are actually pretty recent guidelines that have been published by both
Mm,
the Thyroid Association and the Endocrinology Association in North America. This is something that people are looking at. When we test everybody, we often are picking up things that we don't need to be worried about. And
true.
what that means is we then actually take the test result less seriously. And
Mm,
so
that's a good point. Yeah.
it's important that we don't move to universal testing unless there's a benefit. But I think what I've said is that there is a slide that clearly says who should you test. And it's always helpful when you're making a practice change, print that slide out, have that somewhere in your clinic, even put it on a little laminate it, put it up on the wall. As we
Yeah.
make practice changes, that's really helpful. I don't know how other people do practice changes. When we were doing TDAP, because we were needing to remind ourselves to talk to every single pregnant person about
Uh,
having
the-
TDAP as part of their care. We actually created a little slip that our our MOA gave to every postpartum patient when they came into the office, or every pregnant patient when they came into that office for between 24 and 28 weeks. And then we saw them with that slip. And it was like, okay,
Yeah.
today the doctor's going to talk to you about Tdap. So whenever you're making a practice change like this with thyroid disorders, it's how are you going to cue yourself to remember that? So whether
Yeah.
it's that you make a postpartum checklist and you've got it on there,
Hmm.
whether it's you have a little poster up just to remind yourself in your office so that when you're in there with the patient doing postpartum care, you're thinking about it, trigger your brain some way to remember this new practice change. And once you've done it for a while, then it becomes second nature. Of course, now I don't need something to clue me in
Right.
and remind me
Absolutely.
to
Yeah.
talk about Tdap. But certainly thinking about the thyroid is going to be something that I'm going to be doing in my postpartum visits with people in the future.
No, absolutely fantastic. And you made a good point there. Whatever helps to remind us, when we're changing, and especially also when a team is involved, getting everybody on board and making sure everybody has the tools they need to implement that change. You mentioned something that you will have in your presentation, the slide where, that people can print out and hang to their wall, like their little cheat sheet. So what else do you hope our viewers will take away from your presentation?
Well, I think the most important thing that I want them to take away is the fact that when we tell people about what's going on for them and what it might lead to in the future, we are always improving care. So, for
Hmm.
instance, if you have a patient with type 1 diabetes, letting them know that they need to be screened for their thyroid regularly during the postpartum period. If you have someone that has a postpartum thyroiditis, letting them know that they need annual testing to see if their thyroid is working well after
Hmm.
their pregnancy is really important. If you have someone with Graves' disease who's pregnant, you can educate them and you can inform them that they're probably going to see some improvement in their hyperthyroidism during pregnancy. They might be able to reduce their dose, but postpartum, that's going to come back. They're probably going to have to increase their dose, and then they become the best advocate possible for their own care, and that's how we actually
I like that.
really begin to
Yeah.
change health. And the
Yeah.
one other thing that I want people to take away, that's a takeaway for me, is iodine supplementation is important. It's hard to get enough iodine in your diet. And so I've sort of used to be sort of early in my career, oh yeah, you got to take your prenatal vitamins, but then I realized how expensive they are, how that's such a
Mm,
barrier, how
yeah.
often it is that people find it difficult to remember to take their postpartum vitamin post when they're postpartum and they've got a newborn and they're breastfeeding. But really, one of the things that I learned is iodine insufficiency or deficiency is common. It has a big impact on the maternal health. There's some people that think it may have an impact on the baby's health. So reminding people of the importance of taking a daily vitamin with iodine in it is
Iodine.
really important postpartum. And I'm
Hmm.
going to be a little bit better when I discharge people after their delivery to just talk to people about the importance. The thing that I learned though is it doesn't have to be a prenatal vitamin. I think we forget that prenatal vitamins are about 3 times more expensive than most multivitamins.
Yeah. Hmm.
And in postpartum women, they can actually be using an over-the-counter vitamin. I do always suggest that they check them. There's some natural vitamins that aren't as high in the supplements that are really important. So I suggest that they compare what they're taking to sort of a prenatal vitamin and make sure it's roughly the same.
Same.
But the big thing with prenatal vitamins is high vitamin A can be teratogenic. So the vitamin A is lower in a prenatal vitamin than it is in other multivitamins. And so that's not something that we have to worry about postpartum.
Postpartum. Yeah.
Yeah. And
Hmm.
if they need a little bit of an extra dose of calcium, they can always just pop a Tums,
That's
because
true.
the
Yeah.
calcium is the thing that's a little bit higher sometimes in a prenatal vitamin than it is in a regular multivitamin.
Well, all great information. So much to look forward to in your presentation there for us at Gold. Well, Brenda, thank you so very much. It's been a pleasure having you here, and I can't wait for learning from you at your presentation here for the
Yeah.
Gold Midwifery Conference.
Thanks for having me.
And now some information for our viewers. This presentation, as I mentioned, is part of a lecture pack that we have available for our Midwifery Conference 2026. Yes, it's just around the corner, really. We get started February 2nd, and this is also when this presentation will be available. We have a free and open access keynote presentation live twice on February 2nd, but don't worry, everything is always recorded. So if you can't be there live, that will be recorded as well. Make sure you share that with all your friends and colleagues in the field. And so I invite you to go to goldmidwifery.com. There you will find the information about the entire conference and also, of course, about Brenda's presentation right here. Thank you, everyone, for watching and have a lovely rest of your day wherever you are in the world. Bye bye for now.